Welcome to the second webinar for the Blood-Desert Coalition. Good morning, good afternoon, good evening, wherever you're sitting in this wonderful globe of ours. My name is Caroline Wangamati. I serve on the board of the AABB. I'm also a National Blood Ambassador for Kenya. And I'm equally just very, very passionate about matters blood. And today, I want us to focus on a very special topic, and that is the topic of how can we make blood more accessible in areas where traditional methods may not work. I serve as the lead for the Communications and Advocacy Working Group for the Blood-Desert Coalition. And what do we do? The Blood-Desert Coalition knows that globally, there's a massive shortage of blood. We have so many women and children that are dying. Millions of people are dying from these preventable deaths every year in the areas which we designate as blood deserts, areas with little or no access to life-saving blood products. So you find that conditions that normally would just be treatable, which is a baby having anemia, or a mother that's hemorrhaging, or somebody that's injured from a road accident, are leading to needless deaths, when if we would just have had a simple transfusion, we would have saved that life. And you find that these blood deserts actually exist all over the world. They exist in rural areas in my continent, which is Africa. They exist in Southeast Asia. And even recently, we've realized they also exist in the high-income countries, in some of the sparse populations like Alaska in the US. So blood deserts actually do occur in different places in the world. It's not just unique to the LMICs. Next slide. So the Blood-Desert Coalition, which was convened at the Harvard-Radcliffe Institute, is an international coalition of practitioners, obstetricians, surgeons, and experts in military and civilian transfusion and policy and patient advocacy. We stand with the vision of no one should die from a lack of blood transfusion when they need it. And our mission is to establish the research, the education, implementation agenda needed to eliminate these world blood deserts so that we save lives and we avoid the needless deaths that we encounter. We currently work with about 4 strategies that we are looking at. If we could just move to the next slide, please. The last webinar that we held, we were talking about the walking blood banks, which is a point of care blood screening, donation, and transfusion, really largely innovated by the military and now being adopted in civilian settings in many places in the world. Today, I want us to focus on the drone delivery, which is where we're flying blood where it's needed, when it's needed. So it's a just-in-time inventory system that the Blood-Desert Coalition has focused on. We also have the intraoperative auto transfusion, which we shall be convening at a later point to discuss it, and the use of tranexamic acid as a first-line agent to minimize blood loss. But for today, I want us to focus on drone delivery, and I will be moving on to the next slide as we discuss a little bit what it actually does. The drone delivery is a basic mechanism where you have a request coming in for blood, and the blood is moved using an unmanned aerial vehicle to the place where it is required. That unmanned aerial vehicle, which we call a drone, can come back with even other medicinal products, but it can actually take the blood to where the patient is, or it can take the blood to a facility that's near where the patient is. The Blood-Desert Coalition went ahead and published a white paper and a consensus statement on these strategies: the drone-based blood delivery, the walking blood banks, civilian walking blood banks, and the auto transfusion. And I welcome all of you to go to our website, to the Blood-Desert Coalition website, and read a little bit more about this. But for today, I'm joined by really amazing, eminent experts that are going to help me just delve a little bit deeper into the issue of drones. My own experience just working with rural communities in the place where I was born, it's called Bungoma County in Bungoma, is you realize that so many lives are lost because of the delay of the blood product getting to where it's supposed to be on time for it to be transfused into the patient. So you find a facility that could probably even transfuse a mother, but it doesn't have blood. But the blood could be available elsewhere, in which case, if it was brought into that facility, we could save that life. And we say today, let us speak to the experts, people who have worked with logistic companies in the blood space, people who are working in the global surgical space, and people who are working in the transfusion space to try and just unpack this a little bit. And I'm joined by really wonderful gentlemen. The first person that I would like to introduce is Dr. Pedro Kremer. He's the head of global health impact at Zipline, which is a company that's specializing in autonomous drone delivery, particularly for medical delivery and humanitarian aid. I've actually seen the work of Zipline in action in Rwanda in Africa, and it's a wonderful initiative. Our second panelist will be Dr. Jacob Pendergrast. He's a hematologist and blood bank medical director, University of Health Network in Toronto, Canada. And our third panelist is going to be Dr. Juan Puyana, who is a professor of surgery, director of global health surgery, University of Pittsburgh. But I also know, O'Brien Chair of Global Surgery, Royal College of Surgeons of Ireland, University of Medicine and Health Sciences. He also serves as a co-principal investigator for a very large program called the Blood-Safe program that's NIH funded, that's looking into availing blood in LMICs, specifically for Rwanda, Malawi, and Kenya on the African continent. So with that, allow me to go straight into the questions, and I'll start with you, Dr. Puyana. And I just want to ask you, how important is blood for surgery? And what encounters have you had where clinical care has been affected when blood has not been available, whether it's in the LMIC settings or the high-income settings? Over to you, Dr. Puyana, please.
Thank you very much. I think this is one of the greatest challenges that we have in global health, specifically not being able to provide adequate and on-time blood supply is one of the greatest deficits in developing universal health care and in creating robust health systems. When we look at the funders today that have given tremendous amount of money to develop vertical programs, such as a program for AIDS and a program for malaria and a program for tuberculosis, they fail to see that a vertical program will leave things behind and will create disparities. Developing a blood system is fundamental to provide a horizontal intervention that will supply blood to people who need blood, like in the AIDS program. In fact, PEPFAR subsidized blood banks for a long time. When PEPFAR money withdrew, the blood banking systems in many countries collapsed. So I don't want to make this a very long answer, but creating a system that can secure us achieving the developing goals for 2030. If we don't deal with the need for blood systems, we will not meet universal health coverage. Drone delivery is one of the many things we need to consider to bypass all the tremendous difficulties that are typical of rural areas in many places in the world, even in places with high-income countries. Over to you.
Thank you so much. I like the point you make that blood is actually a centerpiece in a health system. And in most cases, that gets forgotten. It's siloed. I like to use the word, it's locked somewhere in a laboratory, and people forget how important it is until you have a patient that's bleeding. And I think thinking of it that way, I just wonder, Pedro, how did Zipline think of drones, and what motivated the idea of using drones to transport blood? Because it literally leapfrogged this technology into a space that really had a great need. And I just want you to share the experience of what made you, for example, go to Rwanda and make this great success story that you've done. How did you arrive at that, and what motivated you as a company to get into developing this technology and running it very successfully in settings that otherwise will still be facing a lot of challenges in getting access to blood and even other medicinal products?
Well, thank you, Caroline. I first have to say I wasn't in the company when this happened. We're talking 10 years ago. But basically, the fundamental piece of designing and developing Zipline was a blood desert in Rwanda. Our founders were there in 2014. And what they realize is what later become, and for everyone here, very likely it's a very known fact. But they saw there that they needed 4, 5, or 6 hours to reach a hospital that was in need for blood, and actually the hospital was just a few miles away. It was just that the road conditions were making that delivery impossible. When they put that side by side with the maternal, in this case was maternal mortality, Rwanda still has, but had a huge issue on postpartum hemorrhage and maternal mortality. Putting those two statistics side by side, the lack of access and availability of blood and the damage that was causing, I think it made it kind of a natural outcome of that, of that landscape. You needed something that could leapfrog those 5, 6 hours. In some cases, where it wasn't a matter of hours; it was just no delivery possible. Right? There was flooding. There was just no way to get there. And Zipline made its first delivery of blood in 2016, almost 10 years ago. Operations were just for 4 hospitals in Rwanda, and that was the beginning. This was like 1.5 million flights to the past. This is where we are right now. And exceeding blood, right? Yeah.
Excellent. I had an opportunity to see that in action, and it's really amazing, the system that Zipline uses. And I just have to wonder, because we're speaking very much about an LMIC context, and Jacob, I know you are sitting in a transfusion ecosystem in a high-income country, and I just wonder whether in your standard operations, standard protocols, do you see any circumstances where drones could offer any value to a high-income setting, or do you have any populations or areas, geographical areas within a high-income setting that you think could potentially also benefit? Because likely it's been targeted for LMICs, but I just wonder what you think from your own experience, whether there are areas in the high-income spaces that could also benefit from a technology that gives a just-in-time delivery of blood and blood products.
Yeah, no, absolutely. And in fact, Canada, some communities within it were actually quite inspired by the success Rwanda had with Zipline, with drone delivery, in attempting to come up with a similar distribution system in our sort of northern, rural, and remote areas. The context in Canada is quite different than Rwanda, obviously. I mean, I think the funding for the healthcare system differs. The proportion of the population that lives in rural areas differs. I think it's something like 80% of the Rwandan population is rural. It's maybe 30% in Canada. There is a higher proportion of paved roads in Canada. I think something like 25% of roads in Rwanda were paved, I think, when Zipline came in, and most roads in Canada are paved. But probably the most relevant major difference is just the vast distances involved in northern Canada, and the weather is an issue. And the weather is particularly important because on one hand, I mean, this is a challenge to drones, in terms of the amount of energy they expend flying in wind, the effect of cold on battery function and that kind of thing. But it also becomes an issue of safety for pilots. And there are situations where manned aircraft, helicopters or fixed-wing airplanes are not deemed safe to put into the air, to go and collect a patient. But a drone would be a reasonable risk to deliver blood to that patient. And so there have been experiments, using different types of drone technologies to deliver into sort of indigenous populations in the north, where it was considered to be just almost too dangerous to put a manned flight into the air. But there are different challenges as well. Again, the drones have limited distance that they can travel, and the distances in Canada are quite large. So it would be a different type of solution than Rwanda, but and different drivers for the need for it, but definitely interest. Yeah.
And I think when you mentioned the challenges and talking about some of the logistical challenges, I come back to you, Dr. Pedro, and because you have had the experience with this, I just want to know what are some of the challenges that you did encounter when you're trying to, to initiate a drone delivery program in a country, and it can be anywhere, whether we take the LMICs or the high-income countries. I want to hear from you. What logistical challenges did you encounter, or did you have to overcome? What regulatory challenges did you encounter and have to overcome? And how did you go about some of these things? Because I know that it's not easy. Thinking about my country, I know it was a problem for a long time to get the airspace, to actually clear for drones to fly. I just wonder what's been your experience in that space, some of the barriers that have made it a little bit challenging to implement this, but more important, how you try to work around it and overcome those to be able to still put out this technology that's life-saving for especially people who need blood.
Sure. It is relatively changed now, but as you can imagine, a few years ago, sitting down with an civil aviation agency in any of the countries, particularly maybe in low and middle income countries, and saying we want to fly. The technical term is beyond visual line of sight, right? Because it's okay to fly a drone, but flying a drone beyond the point where you can see the drone, it's a completely different story. Where aviation agencies have a say, of course, and it was kind of like breaking a ceiling that was there, and there is a lot of kind of resistance to change. And when you come up with a new technology like this, governmental authorities and someone can say not right, they are very skeptical, right, and they are very cautious in terms of what is going to happen, right? Is this thing going to fly, and crash with an helicopter or another aircraft, or it's going to fly on top of military locations and take photos, whatever. There are so many things, and takes years, and it really takes and took years to work with each of the civil aviation agencies and convince them that this is something safe. A lot of statistics, a lot of research, even waiting to be able to fly, and then while we fly, we keep reporting to all these agencies saying, hey, listen, we have 100,000 flights, 200,000, no injuries, but it's really kind of making the path as we go. Of course, there is like you break the inertia, right? You kind of solve that friction of the first few agencies, and then it becomes easier and easier. Because for example, in Rwanda, we have so many hundreds of thousands of flights that when we go to another country, we can bring the Rwanda case and say, this really works. But that's just in terms of the regulation and the logistics. I would say that the configuration of the blood system is a challenge. People think of Zipline or maybe other drone, area logistics companies, and they see the drone. But there's a component that it's even more important than the drone, and that is how we work to centralize the supply and to make sure that that supply chain is not broken on the way. If you see how Rwanda had configured the blood system before Zipline and after Zipline, there's a complete change based on centralization and drone delivery, not just drone delivery. And then lastly, I don't want to take a lot of time, but definitely when there's an upstream shortage, when there's no blood, you can have as many drones as you want, and you won't have blood. So we work already, with blood drives and trying to make sure that there is enough donation and there's no, those types of problems, to make sure that we will have something to deliver. Otherwise, our distribution centers would be empty.
I'll come back to you on that one, Dr. Pedro, because I actually had a comment from one of the people attending, and I thought you'll have the perfect answer, so you'll address that. But I want to come back to Dr. Puyana, and just when you look at the areas where we've discussed the use of drones, especially, if you take a country like Rwanda, it's part of the standard of care that's being used. If you take different other places, it could be only for, emergency care. I just wonder, what's your thinking about, do you ever see a point where we can now bring the drone technology, and whether you take it, and I want you to think more from the surgical perspective. Is it something that we should only work with when we have emergencies, or do you see a time when it can actually be part of the protocols that you have? And I'm thinking of it from a perspective where I'm just wondering, can you foresee a scenario where this can be part of integrated care so that we make sure that whether it's blood or even other products that the drones can carry are available for the particular client? And I know you have that great global experience. Could you just share your thoughts or perspectives on that? Oh, you're muted, Dr. Juan Carlos.
I think that Pedro made a very important point in his last intervention. There is no point on any system, drones or otherwise, if the region where we want to create these solutions are not prepared to actually generate the amount of blood that is needed. And I think it will be a tremendous mistake, like many that has happened when good ideas are partially or wrongly implemented in LMICs. Sometimes we feel that because we own a hammer, then the whole world should look like a nail. And if the studies and the analyses that are necessary to investigate the feasibility and acceptability of a drone system does not go along with a mature blood transfusion program, then there is no point in doing it. So that's one point. Number two, I think in this area, size does matter in many, many ways. Rwanda fits 27 times in Kenya. So if there was a place where Zipline was going to be successful, Rwanda was the perfect place to do it. Why? Because it's a relatively small country, and perhaps geographically, it would allow for this system to be so effective. I think that if we were to expand or use the successful story of Zipline and Rwanda, a number of very important modifications will need to be developed to create viable solutions in other places. Rwanda fits 389 times in Canada. So I think that it will be nice to have some sort of a clear definition of what a unit of coverage is, like we do in trauma, a regionalization trauma program where you, for example, Pittsburgh has 15 helicopters and we get a population that covers half of the state. Well, some sort of similar mathematical model will need to say, for a region that is the half size of Pennsylvania, we need 17 helicopters to move patients for emergencies. How many drones, bases, pilots, people, blood banks will be needed to supply that particular region? What is it, the minimal size of a region with the minimal investment of a drone system that will be needed for the program to be effective? I think those are questions that remain yet to be answered, not taking any credit of the amazing accomplishments that Zipline has achieved in Rwanda.
If I could follow up on that, I think, this is an incredibly important point. And I think, that ratio of 389, that's actually how many times Rwanda could fit into just one province in Canada, which is Ontario, which is the one I'm working at. So yeah, the distances in Canada are absolutely vast. And if I recall, the maximum flight distance for one of Zipline's fixed wing drones is like 125 kilometers. That will not cut it with the distances, that we're talking about, unless you had many, many nests, to fly from, which is a possibility, in that, every hospital or, somewhat, medium-sized hospital could theoretically be a nest for surrounding rural hospitals, depending on the type of drone technology you wanted to use. It might make more sense with a traditional quadcopter approach, where you don't necessarily need, the slingshot technology to get it into the air. I also if I could just follow up as well on the issue of, putting primacy on the supply of the blood products. Absolutely. There's no point creating this very high-tech distribution network if there's not enough blood to distribute. I did think it was really interesting, though, when I was, talking to the people working at Zipline in Rwanda, and just some of the analysis that had been done there. And one of the effects that they had shown with having that sort of very rapid, delivery capacity was that the local inventory kept at each hospital actually decreased. They didn't need to keep as much on hand because they could get it quickly. And discard rates decreased as a result of that, meaning that it was a more effective way to stretch your available inventory. So it's not necessarily one versus the other. You can actually achieve your goal of improving your supply by improving the efficiency of your distribution network. But I think Rwanda was in a particularly good place, in that it has a pretty robust blood donation culture within it. It's something that is considered sort of a civic duty, and so their blood donation rates, are pretty good, for the region. And I think that was an important first step that they pursued first before they brought in Zipline.
I think, thanks, Dr. Jacob, for that. And I really like that idea of the blood supply. So you guys have covered a question that I was going to ask, because one of the studies, and I think Dr. Pedro, you could speak to it later on, is that when you bring such an efficient mechanism of actually delivering blood, then you create demand at the facilities, because people now know that they can find the blood. So there's more need for blood. And if you are not doing anything to generate more blood, whether it's the mobilization drives or whatever it is you need to do, then we are not really helping, then the drones will not have anything to transport. I want us to come a little bit into, and I'll start with you, Dr. Jacob, into the funding issue. And this one, I want to hear from the three of you differently, because one of the things that instinctively come into all our minds is that it's very expensive when, to implement a drone system. And I know studies have been done that make a very good case for the drone system and are able to speak to larger impacts beyond just cost. And I think I want to hear from Dr. Jacob, thinking about one, just, the centralized transfusion systems. Do you see whether drones could come in? How do you deal with the emergency shortages? Do you think drones could help you? What would be the cost implication for that, especially thinking about some of your rural facilities? And that would be for you, Dr. Jacob. And I think for you, Dr. Pedro, I hope you can speak a little bit to some of the studies that you have done that are able to demystify this a little bit and convince the doubters, because many of us, including myself, until I read some of the papers, I automatically just say drones are a no-go because they're very expensive. But I think when you read the studies that have been done, it tells a different story. And then when we come to you, Dr. Puyana, I also just want to hear your insights from that, especially when you think about holistically, what's the cost of care? Do we measure from the cost, or do we measure the result, that benefit? So I think I'll start with you, Dr. Jacob, then we just go around the room and have a little bit of a talk about this funding and the good and the bad around it. How we're
I think this is one of those questions that as you start to kind of unpack it, you get to some sort of kind of interesting philosophical challenges. So I think if you contemplate the idea of a blood desert, right, which is we've defined as a place where care is being provided that you cannot get blood products to in a timely manner, at least 75% of the time. Nobody wants to, have that's not a good thing. That raises the question of, like, somebody is going to bleed to death in that spot. And so it becomes a problem that, cries out for a solution. The challenge is that fixing that solution with drones means spending money, or anything that improves your supply of blood products to that point of care. Simply removing that point of care saves money. And so from a governmental perspective, you can actually, quote unquote, fix the problem by simply shutting down the hospital and saying, we can't afford to have a hospital in this particular part of the world. And, this is a challenge that even high income countries face, and in Ontario here in Canada, when there was contraction of healthcare spending in the late 1990s, dozens and dozens of hospitals were closed. They said, like, what, we can't afford to have little hospitals all throughout these little towns. And it's kind of, on you as, the paramedic, or the patient who was calling for help or choosing to live there, to find your way to a larger center. So it becomes, the onus is on you to get yourself to a treatment center. from a government perspective, that's a better solution, because you have saved so much money by closing the hospital. And so long as you can evacuate the patients quickly enough to a place of treatment, then hopefully there are no impacts on healthcare outcomes. But that's a gamble. Like when you start doing that and tightening the margin more and more, you're more and more susceptible to glitches, a blizzard where you can't evacuate your patient, for example, or another country might have a flood that washes out a road. So it becomes more a question of how much risk do you download onto the patients themselves for choosing to live where they do? Knowing that if you are living further and further away, you are taking a bigger and bigger gamble. I thought one of the things that was interesting about Rwanda is that it set a goal for itself of having care being provided to its entire population within a most 25-minute walk. That is a standard that Canada will never, ever be able to achieve, and so there are vast areas up there where there is no point of care nearby, and there are people living in those communities. And the solution to that is simply to say, call for a helicopter to evacuate you if anything bad happens. That is not a particularly expensive approach as opposed to building a hospital near them or having emergency supply of blood come to them. But it creates a hazard. Most of the time that works, sometimes it doesn't.
Yeah, it's a bit of it's an interesting discussion. I think I look forward to having more research. I want to have your thoughts, Dr. Pedro, on just that issue of drones are very costly. That's the narrative. And as you speak about that, I can see we have a very wonderful question in the chat, and I just thought you can address it. There's somebody, a surgeon from South America, and he's saying that I suggest to put an example in Latin America, Africa, Asia. How can it be implemented? Put it in real context. The Amazon region, for example, where we work as surgeons. So this could be, you shedding some light on if somebody, that surgeon's working in the Amazon region today, which is where that wonderful gentleman is from. How can this work for them? So I want you to address that question in the chat, but at the same time speak to the funding conundrum when it comes to drone delivery.
Sure, thank you. Well, there are many things I would like to unpack in just a couple of minutes. So I actually first want to recover what Juan Carlos and Jacob were saying about the Rwanda as a perfect laboratory for drones, and that's absolutely true. We do have that math in terms of how many distribution centers we will need in countries in which we already operate, like Ghana, way larger, or Kenya, way larger than Rwanda. In Ghana, we started with 2 distribution centers. We are already, we have 6, we're planning for 8, and we are roughly covering half of the population. It is a lot, right? But there's a lot more that we will need. We work in Nigeria. Imagine Nigeria, each of the states is huge. So yes, I think there's a lot of work to do. What happens, at least with these countries, is when we put one distribution center in one place, like we did in Ghana, we saw that one of the distribution centers in Ghana was contributing to reduce maternal mortality by almost half in that region. Then what happens is that the government sees that and say, okay, we need to think of other distribution centers in places, and you have to target that, right? You have to see where it works. You have to also consider that our drones, that technology we have right now operating in Africa, cannot fly over urban centers, for example, or cannot fly over airports, or cannot fly over military bases. So it's not so straightforward. But I totally acknowledge that. That's why Zipline actually unfolded this second technology, which is the more like the traditional quadcopter to fly over different environments, mostly cities, not operating in Africa so far. On the terms of cost, Caroline, and I think that what happens, and you can imagine, we receive this question a lot, like how can it be so expensive? And usually what happens is I say, I can put 2 units of blood in a motorcycle and it will cost me like 10 cents. How can I be paying like so many dollars for a flight? And that is when my response at least, is we can talk about cost, but we should talk about value, right? We should talk about effectiveness and cost effectiveness. If you can't just say, I am only looking at next year budget and I cannot spend this amount of money, and we get it. That's how governments usually work. But if you can expand that a little bit, and you can see that beyond the amount of money that you save because you have less people dying, even though what Jacob was saying is totally right. It's very cheap to kill someone, right? Not to treat someone. But when you do cost effectiveness and you incorporate not just that, but also, for example, these are things that not even ourselves in our studies were planning to identify. The inventory management, yes, they have less inventory, they have less wastage. In Rwanda, it went down to 0.02. There's almost zero wastage. So that's money, right? And then you can also see that, for example, low weight birth was reduced. Institutional deliveries increased. And things that are, surgeries, emergency visits. You put all that together, then you realize that not in 50 years, but in just a few years, you get your money back and more. So I think it's a matter of changing that mindset and saying it's not just about the amount of money I will spend next year, but what is the return of that investment? And just to complete this, there are things that are, this is what you were saying. We were definitely not expecting 20% increase in antenatal care visits, because we would say antenatal care visit is something that usually doesn't need iron and vitamins, but this is not drone dependent. It's not medical products dependent. But what happens is that in this, there are many examples of this in the literature. When a facility becomes responsive, when there's someone to take care of you, then people go to a facility. And the opposite happens, right? You know it will be closed, there will be no blood, there will be no whatever, and you're just going straight to the hospital, right? A lot of money spent, wasted on that. Antenatal care visits, postpartum depression. You say, what does it have to do with blood delivery? And apparently it has, just because there is trust in the system, there are preventive consultations, there is more promotion, and then you see, for example, less breastfeeding complications. So I know it seems like I'm going very far here, but you have to put all that to understand that the value is way, way more than just not paying for a motorcycle that will likely, waste 2 units of blood and won't save anyone. And sorry, I know I took too long.
Yeah, I loved that paper that you presented. I mean, to just see the impact. And for us in our context in the LMICs, the antenatal visits are a lifesaver for the mothers. It is where we identify all the problems. It is where we capture whether you're anemic, whether there are challenges to you or the baby. So to think that just having the drones and building that trust is promoting that is a big win for us in the LMICs, because one of the things I advocated for so many years is for the mothers to just do their 4 antenatal visits. And to think that that was almost like an uncorrelated outcome that came out of this just speaks to the impact of what this is doing, because what you're doing is you're improving the health-seeking behavior of the population. You're building trust. They can trust their system and they can come in. And that in itself is a big bonus, because then you're able to monitor and take care of the health of that population better, which I think is an amazing thing. And I think, Dr. Puyana, as you comment on the funding question, as I like to call it, I also want you, just because of your experience at a very global level, I want you to speak to what kind of partnerships, if we are to go into these spaces like drones. So we think the funding, but we also think who are the people we're supposed to be talking to? What are some of the partnerships that we need to be looking into? And I really want the perspective of in this case, a caregiver, a surgeon, because sometimes the policy people speak louder than the people who actually use the commodities. And I think I want you to bring that voice to the table. What are the important considerations that we need to have? There's a funding angle, and then there's the partnerships. So if you could just speak to that a little bit as you take on the funding question.
What really keeps me awake at night in my job, now that I'm sort of almost 100% dedicated to global health, it's the word sustainability. We use it a lot. We write it a lot. We talk about it a lot, but we have failed yet to create the financial models that will create financial independence. This has been an important year in the history of humankind. The USAID sudden shut off of aid has given a wake-up call to many places in the world, not just Africa, who depended on aid to subsidize their health system. I am not saying that what the American government has done had any reason to happen the way it did. And I am saying that irresponsibly, this is going to actually have a tremendous repercussion on immediate mortality. I think people are going to be dying, if they're not dying already, because they don't have access to something they have assumed they were going to get. So putting that aside, this is a critical time in our lives to begin to answer the question, or perhaps to begin to ask a different question. How creating in this case, a drone program for Ghana or Kenya is not only going to be supported economically, because the Ministry of Health only has so much money. When I was sitting last week with the Minister of Health of Malawi, she was telling me that they had a polio epidemic and what's the name of that pox new virus that it's becoming, yes. So she was saying that they were having cases in Malawi. No one in Malawi has traveled. So how did those things got there? So it takes you a few minutes to talk to the people who are actually making decisions and how they're going to use the little money they have. How much is the financial budget of the Malawi Ministry of Health for us to go and say, oh, Malawi has to put all this money on a drone program. So let me tell you, just to finish, I'm going to be a little bit of a devil's advocate, and I don't want to end up on a negative note. Can we actually make business with the drone? If we move the drone from A to B with blood, can the drone come back with something from B to A that can be sold, purchased, trade, medical devices, I don't know, medical supplies, things that move back and forward? Can we make drone not only the system in which you deliver life-saving medications and blood, but the system you actually create a new partnership of trading? I think we need to think outside the box completely, and we need to, every time we talk about global health, we need to have a way of saying, what are the smart financial implications of creating a value to the market of what we're doing, so that you can actually create money, jobs, an economical underground that is fundamental to everything else we do. And I am not anyone who can talk about economics in LMIC, but I think if we don't think about that, and if we don't think, okay, can we make some sort of energy, some sort of water purification, some sort of food process, so many things, so many resources. Why is it not possible to start thinking, what does Malawi or Mozambique are going to need to become countries that no longer need aid? And maybe I'm going off the tangential here, but I think that a program that is, as you said, expensive as drones, but Pedro has told us, no, when you do the cost effectiveness and the value of this is amazing. Okay, add to that what it will take to create a business to support that. Is that too crazy? Maybe it is. Maybe maybe I smoked the Kool-Aid too soon. I don't know. Go over.
And I think you're right. I think this year has been a shocker for a lot of countries, with the pull out of a lot of money from the USAID, and even what's coming up with the WHO. And I think the reality is that a lot of countries are really, for the first time, having to grapple with this. And I know for us in the blood space, we worry more about this, because even traditionally, when we had all those funding pools around, we still were disadvantaged as the blood space. So for those of us in the advocacy space, our biggest worry is what happens to blood now, when even the malarias and the TBs are gonna get less money. And I think it becomes even more essential for us as the BDC and any of the people in the blood space to come out a little bit louder, because the risk we run is that blood will be pushed back. And I like what you say, Dr. Puyana, because we have had this discussion separately with other people. It needs to become a bit of a business. It needs a mechanism for that money to rotate. And I think I've always believed, looking into issues like cost recovery, looking into issues that make it make a business case for doing that is what will make sense eventually, because positioning it the way we position it as a free product in itself is counterproductive, even in terms of the narrative that we give to our people. But I want to, just because I can see our time is running out, Dr. Pedro, you're our transfusion specialist here. Do you think the safety of blood is compromised, or blood products, when we carry it using drones? Because I know the drones kind of drop it. And I know Pedro could answer the question, but I think I want to ask you as a transfusion specialist so that you give a more unbiased perspective to it. Do you think the blood will still be safe? Will we have more hemolysis or any of the things that will happen to blood when it's dropped by drones, or if it's carried using the traditional methods?
So I think, you have to, for labile blood products like red blood cells and plasma and platelets, there are, shipping conditions that have to be maintained in terms of temperature, in terms of maximum time, for platelets off an agitator and that sort of thing. So those are definitely parameters you have to operate within, when you are, coming up with your packing configurations. Do you have to put like cold packs in there? Do you have to sort of set a maximum time in transit? These are all totally doable. These are not insurmountable challenges at all. And it's interesting to note, that there is a growing trend in the blood transfusion world away from labile blood components and towards what are called fractionated plasma products or plasma derivatives, which are sort of ultra purified protein concentrates, of coagulation factors or colloidal proteins, and that sort of thing. Those products, are much more stable. They don't require the same kind of rigorous temperature requirements. They can be stored for much, much longer. They're lighter. So there's a lot of advantages to using those products, and the drone delivery would be particularly valuable for things like that, or for sort of low volume products like RH immune globulin, for women who are at risk of being sensitized during a pregnancy. So there's all sorts of potential there. But even for traditional things like red cells and plasma, totally doable. You just have to make sure you have chosen the right kind of shipping container and packed it appropriately with insulating material. Just wanted to comment as well, the sort of the issue of, can we kind of like piggyback another business on top of the delivery of blood products by drones? And I feel like that is inevitably going to happen. There are all sorts of reasons that we pave our roads. For example, once those roads are paved, everybody uses them. Everybody finds a value for that. And I think if you come up with a very robust and reliable drone delivery system, there will be all sorts of businesses that will be asking if they could, pay to have access to it. It will get a little bit tricky, I think, in terms of separating, the agricultural products from blood products to make sure that there's not, cross-contamination and that sort of thing. So you have to do a little thinking about this, but I feel like that's inevitable. Once you've built this, the same way if you build like a telephony or internet network, businesses will come and ask if they can make use of it.
I like that, Dr. Jacob, because I was speaking to a company that's trying to pilot drone technology in Kenya, and their prime customer is actually oil companies that are drilling oil in the northern part of the country, specialized parts. And I found that to be so weird, because I always think of drones for delivering, like clinical products. Like in Kenya, we are piloting, we are actually using them to deliver vaccines and other medicinal products. Of course, we are looking into blood samples and all that, but it was interesting. They actually want to use the drones to deliver machinery for the oil equipment. And so I think I like that thought. There's a question in the chat, and I'm thinking maybe, Dr. Pedro, you could give us some thoughts on this. And it says, does the ability to quickly deliver blood reduce the motivation of low population areas to donate blood? So if blood can be delivered from elsewhere, what is the motivation of blood banks to organize blood drives in their areas? After all, we can just call for the blood and it can come in from somewhere else. And I like the way this person has framed the question. You know, they said there's a trade-off. And has it been difficult to balance between profit versus social good? So a bit of that balance. Do you, in your experience, have you had that where there's less motivation to collect the blood because we know the blood will come in from somewhere anyway?
No, not in my experience. I think that, and I also wanted to just take 30 seconds to recover what Juan Carlos and Jacob was saying about the business side of it, because it's something that we're already seeing and not something that we actually planned at the beginning. For example, in the case of Rwanda, where we have more time operating, Zipline is delivering swine semen for farmers, right? Zipline is in conversations with the Ministry of Tourism because there will be someone, you know, in a safari somewhere in the country and will need something to be delivered at the hotel where they are. And you would say, does it has to do with, you know, saving life? Probably not, but it has to do with making this more sustainable. So I think that it's like I think it was Jacob saying, once you build it, this is like an air highway, right? Once you have the mechanisms in place, everyone should use it. And now in Rwanda, for example, the Ministry of Agriculture is paying part of the bill, and the Ministry of Health is paying just less of that bill. And the idea is others, right? There's a country where we are talking with the mail system, just for, you know, letters and pensions and whatever they need to distribute. So it's a matter of using this platform that is already operating and it's efficient. Yeah, I didn't want to forget saying that. And then in terms of blood, you know, we see blood as a social good, not as a commercial product. It's not something that you will sell like you will sell a cellular phone. And what we see is that what really affects the motivation to donate is to know that when you need it, you'll have it, right? What we see, Rwanda has a beautiful system where, you know, it's free, but we work in other countries where you have to pay when you receive blood. Either you pay or you bring someone that can, you know, kind of replace that unit, and that is the main thing that affects, you know, blood donation. That's why in for example in Ghana we have to be all over the place working in blood drives, and in Rwanda we don't. And I think that's what motivates people to donate, is knowing that you will get it when you need it. It doesn't matter where it comes from. But that's just my perspective. I'm very curious also from Juan Carlos and Jacob, see what they think.
And I like what you say, because the biggest challenge we have when we're organizing blood drives, even right here in Kenya, is the people who donate always tell me, but I'm donating blood today, but last week when somebody that I know needed blood, they didn't find blood. So what you're saying is that by solving the problem of blood being available, it actually becomes a motivation for those who are willing to donate. So it's actually not what we thought, that, you know, it could detract people from that. So as we close it off, we just have about 7 minutes. I think I want to go around and just get your closing thoughts. And I want to start with Dr. Puyana. You're a founding member of the Blood-Desert Coalition, and you are part of the team that really worked through these strategies. And you know that the strategies we worked on as BDC are supposed to be a stopgap measure for when the standard blood banking is not available. So just to put Dr. Jacob at ease, there is no intention to ever replace the standard of care methods. I just want you to give your closing remarks as to where we envision the drone delivery as BDC, how it sits in the emergency care, having that good overarching global overview, and whether you think this is something that really we can practically try to expand to just make sure that we are not losing lives in spite of the perception around costs and all the logistics that come with it. So I think over to you, Dr. Puyana, and then I'll come to Dr. Jacob. I'll put you a different question as we just do closing remarks.
So when we did our first qualitative studies already 4 years ago, when we wanted to see the barriers and the facilitators to creating new strategies for improved blood availability and safety in rural Kenya, one of the things that I was not ready to hear, I didn't know that would happen, is the tremendous stress and the tremendous sort of suffering that a healthcare worker goes through when he or she has to make the decision that is only one blood unit and I need to give it to this patient instead of that patient. So we know that this is a preventable death if we all had blood. We know that the challenges of exsanguinating hemorrhage will continue to be a major burden in places when there is no money and there is no blood. Ectopic pregnancies, postpartum hemorrhage, and injuries are going to only increase with the growth of the population, with the expansion of the population. Everybody has a motorcycle in Africa right now. The amount of injuries related to these are spreading to places where there will be no blood. So we can only say that this problem is going to get bigger, and we need to have our capabilities, our AI, our communications technologies, our way of improving drone technology. I mean, the fact that the Zipline is not a helicopter yet, it's a major limitation in my mind, even though I know nothing about drones. But if you go to Ukraine and you hear that the Russians and the Ukraine are killing each other with these most amazing tools, well, clearly there's a bunch of drones that could be used for the good of the humanity instead of for the destruction. So we need to get hold of every possible resource we have and try to use it to our best. And I love the part that they are thinking about business, even though we're not planning to send their blood. We're going to use the drones to make financial solutions to these problems.
Thank you so much, Dr. Puyana. And as I come to Dr. Jacob, I just wanted to give a big thank you. This webinar was put together by an amazing team of 3 people, and that is Siva Imani, Maya Razmi, and Sida Misra. So thank you so much. In case we run short of time and we don't get a chance to say thank you. Now, I want Dr. Jacob, you give us maybe just a 1-minute closing remark, and I want you to center it on the fact that you work in a centralized and, of course, very modern transfusion system. What are your closing thoughts around the drone technology? Do you see it ever having a space? Is it too removed? What are your thoughts on that?
I think, what I'm really interested to see is as we introduce drone delivery of blood products that result in making it faster to get blood to a remote area than to evacuate a patient from that same place, that this is going to have a possible downstream effect that you are going to see patients increasingly being treated where they are because blood products are becoming more available, which means that all their other healthcare infrastructure will have to be improved, as that patient stays there. So what I am anticipating may happen is that drones become a vehicle not simply of delivering blood products, but of actually, in a way, delivering hospital care, because they are going to make it easier to keep the patient where they are, and that's going to require building up the facilities. I see that as a very good thing. This is an issue of equity. Every patient should be getting the same quality of care no matter where they live. So I think that'll be an interesting dynamic to watch.
I like that. That's very good. I'm a big believer in equity, and I'm a big believer in access. So you've spoken to my heart straight. I think, Dr. Pedro, you're our single expert on drones on this panel. So you have to be the one to close it off for us. Give us your 1-minute thoughts on drones. It's a good thing. Should we do more of it? Give us make it a call to action, as we normally say in global health. Make it a call to action.
I will have to disclose my conflict of interest for this. I am too involved. But I will say that, when I started working on this, I had zero understanding of drones. And I keep being shocked every time I work in an impact study and I see what's happening. To the point where I reach the point where I think that it's not a matter of if, it's a matter of when. I think that drone delivery of blood and other medical products and probably everything else is just a matter of time. It will or will not be Zipline, will be someone else. But I don't think there's anything that can stop this trend. I think people will be sitting in 20 years and it won't be like a novelty like it's now. I think that's all I can say. We don't communicate a lot about this, but we are delivering to the front lines in Ukraine. We've been doing it for almost 2 years already.
Wow!
And
so it's
they may or may not shoot one drone or two, but it's still worth it.
Yeah, absolutely.
Wonderful. My takeaway is that it's not a matter of if, it's a matter of when. And with
Yes.
that, I want to give a big thank you to Dr. Puyana, to Dr. Jacob, and to Dr. Pedro for joining us today. And I want to thank everyone that has been able to sit through with us and to listen and to learn and to even ask questions. And we're still available to answer questions on email. So if you have any more questions or you want more insights, I encourage you to still reach out to us and go to our website, the D.E.S.E.R.T Coalition, and you'll see the publications that we have, and even a recording of this webinar will be there in case you are not able to join or you want to refer a friend to be able to look at it. So I might say thank you, and the organizing team from the Harvard Medical School, thank you so much. And let's keep
thank you.
talking about blood. Yes.
Thank you, Caroline, for
Thank
an
you,
amazing
Caroline.
moderation.
Yes, agreed. Thank you so much.
Fantastic.
We'll see you
Goodbye.
guys. And let's keep talking about blood. It's what I always say. Let's be friendly vampires, you know,
Absolutely.
the ones who don't drink blood. Thank you, guys.
Bye.
Bye.
Okay, cheers.
Bye-bye.
Okay.